Great. So happy to be here and happy to engage our stakeholders and represent CMS and talk about delivery system reform and also your specific concerns about measurement and the quality landscape. A couple things. I'm just going to touch upon kind of the big picture of where we're trying to go in value-based purchasing and where the agency is trying to go in moving how the health system is paying for the services that we render as providers. I'll touch upon our quality strategy and some driving principles. The quality strategy, one of the biggest driving principles is improving patient safety. I think you've all seen that over the last decade or so, a real drive to have all levels of providers and support staff think about how can we minimize adverse events. And one of the ways we feel we can do this is by encouraging communication, not only between providers, but with our patients, getting patients involved in their care. The idea of that is that we can prevent unnecessary visits for chronic conditions, and that we can kind of empower hospitals to be thinking about the care of communities and not just siloed into what's happening in the institution. I think to think about delivery system reform, we have to have a beginning step, and that step is there's a problem in how we are providing care and how our system of payment incents care. And that problem is that it's not just between the primary care provider and the physician, that as care expands depending on the nature of the condition, as more providers get involved, the communications between the patients, the doctors, the techs, all the folks involved breaks down, and there is a loss of synergy. And this is where we think inefficiencies arise, where risk arises as far as likelihood of harm, and where we think there's room for improvement. And what we want to do is create incentives and programs that will improve this kind of messy situation that we have now to something a bit smarter. Historical observation, George Bernard Shaw, who's one of the founders of the London School of Economics, talking in the early 20th century about care in the UK. And I always find this really interesting. I still kind of scratch my head. But I think it really does reflect the problem we still have in the United States. So I'll let you guys mull over that for a moment, that how can we incent better care if we're just paying folks to provide care? His comment specifically was noting that traditional economic theory does not work so well in the healthcare sphere, and that all the issues of asymmetry of information is a big deal, and we cannot expect our patients to reliably depend on what we're telling them when we have on occasion an incentive to do more than we might necessarily need to do. So how are we going to get to this future state where things are aligned? So we have the three-part aim. I'm sure you've heard a lot about better care, smarter spending, healthier people. A big part of that is value-based incentives, paying for smarter, coordinated care. The hope for that is incenting integration, coordination, communication, the stuff I've been talking about. And the backbone of that is openness, transparency. A lot of folks will have read about charges versus cost, Steve Burrell's article from last year or 2 years ago, where patients need to know what's going to happen to them when they go to the hospital, how much they're going to get charged. Hospitals need to do the same with the payers, and that we need to just be more straightforward about how we communicate. At CMS, we're working on this three-part aim through a variety of programs. I sit in value-based purchasing, hospital value-based purchasing, which is not a very big program in the CMS budget. It's $1.5 billion right now, which sounds like a lot, but when inpatient hospital care is in the $300 billion range, it doesn't seem as much. But we have a lot of opportunities to try to work on this problem. Another way to think about our quality programs is by kind of siloing them to where they're focus is. So hospital quality reporting, physician quality reporting, post-acute care quality reporting, and payment model reforms. Hospital value-based purchasing, that payment model reform where we're trying to link quality metrics from hospitals into how they're paid. And that's because hospitals that participate in hospital value-based purchasing, we take a portion of their DRG prior to the year and give folks who perform well on our formula an incentive based on how well they perform. I'll get into that more later. Again, thinking back about George Bernard Shaw's comment, when delivery system reform started, maybe in the 70s with the first instance of trying to get HMOs and moving on into DRG payments in the 80s, the idea was to walk away from direct payment for service. This is a slow process. It's going to be a long process. But subsequent to the Affordable Care Act, we've really made some strides to correct for what we think is a problem in how we pay folks. The types of payments we have can be categorized in four relatively straightforward categories. Most of our payments on the left side, this is still traditional fee-for-service. You do something, you get paid. Some services are now linking quality to payment, and we'll talk about that more shortly as far as the changing landscape from 2010 to now as far as what percentage of payments are linked to quality. The third category is one that I'd emphasize to you because this category is what the law that's like not even a month old, it's passed on 16 April, is going to emphasize. Alternate payment models, bundled payments, increasing the amount of accountable care organizations, having hospitals responsible for care in their catchment area and incenting them to do better. These are the kind of the four general categories of care. Again, going back to kind of our vision, our strategy, Secretary Burwell laid out where we want to go. And where we want to go is to have 30% of Medicare payments by next year, goodness, be linked to alternate payment models. And in fee-for-service, we want 85% linked to quality, just by next year. How are we going to do that? How are we going to do that? A big part of it is work like this, communicating with our stakeholders, practicing physicians, and sharing our vision and having not only providers, patient groups alike join in this work together. It's not going to be a top-down approach. It has to be really the other way around. So we really believe that getting stakeholders involved is the way to success. I think we saw this slide briefly a moment ago. I think this though, I think gives you a more optimistic view of our chances. So in 2011, just after the Affordable Care Act was passed, we had a solid 0% of alternate payment models, right? In 2014, thanks to the work of our colleagues in the Centers for Medicare and Medicaid Innovation, we're about 20%-ish. So next year getting to 30%, is that possible? Yes, it's possible. In 2011, as far as linking quality of payment, thanks to the hospital inpatient quality reporting program and many measures that most providers strongly dislike, these checkbox measures that certainly encouraged me to leave full-time clinical work and try to change the rationale of those things. Those are about 68% of linking quality to practice. Now they're about 80%. And we're hopeful we will certainly surpass 85% by next year. Whether we get to 90% by 2018, I think that was less clear before the Medicare Authorization and CHIP Reauthorization Act was passed, but there's so much incentive and money in that bill to support improving cost and quality measurement and linking quality of payment that I'm optimistic we will achieve these. Just another look at the categories and where hospital value-based purchasing lies. I'm going to spend a little bit more time on that shortly. I'm going to skip over these just for time's sake. So HVAP started with the Affordable Care Act. The idea of this was pretty simple. We want more efficient hospital hospital processes, we want safer care, we want evidence-based care, and we want to rate our hospitals on how well they provide this type of high quality care. As I mentioned before, it's not a lot of money, and it was much smaller in 2013 when it started, but you see year by year the amount of risk that hospitals participating incur increases, and of course the amount of benefit for hospitals that are successful also increases. Most hospitals are eligible for hospital value-based purchasing. There are a few hospitals that are not. Hospitals that don't report measures are excluded, and hospitals that have significant negative experiences or incidents are excluded. We're working on trying to expand the number of hospitals that are eligible. When we think about hospital value-based purchasing, I think it's a really good program to think about how the quality landscape has changed in the last couple of years, with a strong emphasis towards outcome measures and really walking away from checkbox process measures that are strongly disliked by providers, including myself. So this is how it started. So it started with 70% of many checkbox measures, and the reason for this was really simple. We didn't have anything else. It wasn't like people didn't think about outcome measures 4 or 5 years ago. It's that there weren't sufficiently vetted and reliable measures available to include in the program. HCAHPS, the Hospital Consumer Assessment Providers something experience, yeah. That still takes a big chunk, and that's been consistent throughout. But the process measures, what you'll see is from year to year, they drop, right? So a 45% drop, down to 20%, down to 10%, down to 5%, right? So what are we saying here? I think the message is that, A, we understand the feedback we've received from our stakeholders, our providers and hospitals, that these checkbox measures are not improving care. But B, the message we're also sending out is we want to know what's happening to our patients at the end result. The measures we're interested in are about the quality of care at the end of the experience with the hospital system. And we're working diligently to have outcome measures that are reasonable and reflect our interest in not only safety, patient satisfaction, and the final thing we've added recently is cost. To some level of controversy, the Medicare per spending beneficiary measure was introduced actually just this year, and this is our first effort to bring in the context for hospitals that it's not only providing high quality, safe, effective care, but also doing it in a thoughtful basis. So those are the domain weights. By 2017, you'll see that process measures will essentially have been pushed out, and everything will be outcome centered. A couple of comments about how this program is impacting different types of hospitals. With teaching hospitals, rural, urban, we've done a lot of internal evaluation of all our participating hospitals and comparing them to non-participating hospitals. And so far, we're very pleased that we have not found any disparity in how hospital value-based purchasing is affecting hospitals. Particularly for safety net hospitals, there's not a disproportionate impact. Scores aren't worse. Penalties may be slightly worse, but they're not large sums. I think Health Affairs was mentioned a little while ago. Last month or 2 months ago, there was an article saying that the penalties for safety net hospitals was statistically significant and more severe than non-safety net hospitals. That statement is true, but the monetary analysis of that difference was something like $12,000, right? So for most operating hospitals, $12,000 is not going to be something that would drive their hospital into the ground or in a negative direction. And we have a comment about that article coming up next month that you'll all be able to see. The total performance score, sorry I didn't write that out up there, is how we score hospitals. That's how hospital value-based purchasing works. So the total performance score is measured by two components. One is achievement, and one is improvement. This is really important because this program is the only program that doesn't just penalize hospitals for poor performance. So it tends to be very popular for that. Achievement is based on the mean for hospitals across the country and how your particular hospital lands. Improvement is actually based on the individual hospital's baseline performance from last year to how they improved the following year. And depending on how much they improved, they get some money back. So we don't want to just be penalizing folks. We want to recognize that folks are working hard to improve, and when they improve, we'd like to incent them with payment. These are scores from 2013. Darker scores are better. You'll see there are a lot of dark scores and high scores. That's because these were all the process measures that were already known for like 10 years or something. So hospitals had been working on this already. Next year, 2014, see all the colors are much, much lighter. The scores are lower. That's when we introduced the outcome measures that weren't in as long, and hospitals performed much more poorly. Is this a bad thing? Not necessarily. The idea is to incent improvement. So you put a target up and hope that folks will work toward that target. Where to next? There are a lot of areas of interest. I think some were touched upon just a few minutes ago. Patient-reported outcome measures is important. We spent a lot of time talking about how we rate providers and how well they're doing it, how quick they're doing it, is it costly and all that. But if providers do everything great and the patients think it was a crap job and they feel equally unwell after the procedure, like, well, how well did we really do? The Oregon health insurance experiment was the kind of natural experiment of Medicaid expansion that occurred over the last 6 years. It was published January 2014 or ish, and compared folks who won the lottery to receive Medicaid expansion in Oregon versus folks who didn't. There were biologic markers that were followed, like blood pressure, A1C, things like that. But there were other things that were measured as well that I think are really important. Those things were just kind of your sense of well-being. Like, how do you feel? Do you feel healthy? The other questions were around depression scores, a general survey for depression. And what was found in that study was folks who were insured through receiving Medicaid benefited by having more financial security. They were less stressed about the costs incurred from their medical condition, and two, they felt less depressed. What wasn't found is improvement in blood pressure and things like that. The folks who believe that health insurance is a good thing, I think our comment on that is that a year follow-up may not be enough to identify benefits for those physiologic markers. E-measures we talked about briefly. There are so many new gadgets. So I work about once a week now, and it's alarming the things I don't recognize that are popping into hospitals. They're like ventilators. They're sending real-time data to monitors. If there's a way we can get this kind of information available to assess the quality of respiratory care, et cetera, that could be very useful. Population-based measures. Hospitals are being asked for a lot of things. Is there a way to have hospitals more involved in the care of the community? So the hospital is not just judged on how the hospital performs, but perhaps on its catchment area, right? So if hospitals are incented to have more clinics, have more outreach locally, so the smoking rate's better, the obesity rate decreased, et cetera, is there a way we can devise payment models to do this? So this is the kind of stuff that we're talking about. This is all very early stages of development, but the idea is to go beyond the institution itself and to the community where our patients are. More list of potential e-measures. I won't get into this just now. Hospital value-based purchasing, it's really easy to read about for those interested. Just Google it, and you'll see heaps of FAQs pop up. so I'll spare you this. I'm just going to skip to the end briefly. Where does all this work take us? We have a lot of programs. I showed you, probably like 100 different programs that CMS does, and the aim of this bottom line is improving care. So one stat we're very proud of, and that I'd like to mention, is that because of the work that we've been doing since 2010, we have really significantly impacted how care is delivered across the country. 17% reduction in hospital-acquired conditions, that's a big deal. 50,000 saved lives, that's a big deal. Some folks have questioned these numbers. There are a lot of ways to vet numbers. I refer you to our popular fact checker in the Washington Post, who gave our CMS stats a very rare Geppetto mark, which means this is really solid, vetted information, that the quality work that we're doing is actually having strong and real impact nationally. Last thing, as a medical officer, I believe in expanding our insurance coverage. So when you have patients who are struggling with insurance, remind them that open enrollment is coming again, right? So November 15th November 1st is when it opens for another 3-4 month cycle. And for folks throughout the year, there are a bunch of things called special enrollment periods that also make them eligible for insurance: marriage, adopting, not being in jail, things like that. And depending on where you work, this stuff comes up. And if you need to schedule a procedure and somebody's not insured and you identify these things, you can make a real impact in getting something done. So thank you very much for your time, and